Good morning,
sir.
everyone. I think we will start. So today, I would like to specially welcome Dr. Richa Lal. She was formerly the head of the Department of Pediatric Surgery at SGPGI, a colleague with me when I was at SGPGI. She is attending today for two reasons. One, because the patient is a child, and second, because we are discussing the possibility whether we could start a similar online educational activity for pediatrics and pediatric surgery. So Dr. Richa and some of her pediatric and pediatric surgery colleagues have agreed to give some time. So she just wanted to see how things go on. I also see Dr. Dilip Trivedi. Welcome, sir. Richa, you want to say anything now or later?
I'm just happy to be a part of this group, and if I can add something to the discussion, sir, I will do so.
Sure. Dr. Trivedi, you would like to say something?
I think it's a good idea. I have liked the idea, and that's why actually I have come here to join to view, because the DNB students are quite not trained in the presentation. I think I congratulate you for the whole idea.
Thank you very much. Thank you. I think we will start. So Mounica, please go ahead. Share.
Good morning, everyone. Today I'm doing the case capsule. Here is an 8-year-old male child from Kota, Rajasthan. Okay. There is an 8-year-old male child from Kota, Rajasthan, studying second standard, belonging to middle socioeconomic status, presented with chief complaints of abdominal distension from 4 months and bleeding per rectum from 3 days. History of presenting illness. He has a history of painless abdominal distension, which is uniform and relieved by passing normal stool. It is associated with weight loss of 3 kg in the last 2 months. There is no history of obstipation, melina, and hematochezia. No history of painful defecation. No history of mucus discharge. Recently, patient started complaints of painless bleeding per rectum for the last 3 days, which is mixed with stools. Not associated with tenesmus or splash of blood. No history of perianal discharge or awareness of any lump. No history of incontinence to gas or stools or of soiling of undergarments. No history of urinary complaints. There are no other constitutional symptoms. There is a history of blood transfusion 1 month back with complaints of bleeding. Then, however, hemoglobin was low, 6.5 gram%. There is no comorbidities or any past surgical intervention done. And coming to personal history, he doesn't have any history of addictions. He is a non-vegetarian and he has normal sleep cycle. There is no contributing drug history obtained from the patient. Family history: the father has undergone right hemicolectomy at the age of 30 years in 2018. He was diagnosed with adenocarcinoma T3N1, received 6 cycles of chemotherapy, followed up with 3 PET scans till 2020. Details are not available. He was not advised further follow-up. And his grandfather has a history of carcinoma urinary bladder. It is a high-grade carcinoma. Underwent surgery, TURBT, for stage 3 urothelial cancer. Summary: he is an 8-year-old male child with complaints of abdominal distension, relieved after passing stools, with recent history of painless bleeding PR, with a family history of large bowel cancer and bladder cancer.
Yes, Mounica, you said in your history there is no history of bleeding PR, hematochezia, and you gave a history of just 3 days history of painless bleeding PR, and then when later on you said that there was a history of bleeding with anemia for which a child was given blood transfusion 1 month back.
Yes, sir.
So let's go back to your slides one by one. Go to the first slide, please. Even before this, yes. So this is the point Dr. Chaube was asking you. You are saying bleeding per rectum only for 3 days.
Yes, sir.
No history of bleeding per rectum before this.
Yes,
Is
sir.
that correct?
Yes, sir.
Okay, go on. Next. So explain all these symptoms which you have asked for or which were provided to you, because if you were taking the history, you would ask the same thing. So explain the importance and relevance of each and every symptom. What is the purpose?
Okay, sir. He has a painless abdominal distension which is uniform and relieved by passing normal stool, which could suggest that the obstruction could have been relieved if there is some obstruction.
So you are saying that the abdominal distension is because of obstruction. Is this the classical picture of obstruction? What is the classical description of intestinal obstruction? What are the 4 cardinal features?
There will be abdominal pains, sir.
And 4 cardinal features of intestinal obstruction. So pain, distension, vomiting, and constipation or obstipation, isn't it?
Yes, sir.
Yes. So here you are saying that there is no pain. It is only distension.
Yes, sir.
So why do you say this is obstruction?
Because it got relieved by passing the stool. If there was some obstruction.
Yeah. So it would have been better if the statement could also have said whether during the time when the child had the abdominal distension, he could not pass stool or he could not pass flatus. So at least 3 of the features were there. And why there is no vomiting? What does it indicate? Even if you are thinking it is intestinal obstruction.
Sir?
If you think this is intestinal obstruction, but there is no history of vomiting. And we said that the 4 cardinal features of obstruction include vomiting.
Yes, sir.
So what is the possible explanation for that? So the reason is that these are all 4 cardinal features which are classically present, say, in distal small bowel obstruction.
Yes,
But
sir.
if you have, say, colonic or rectal obstruction, then there may not be vomiting.
Vomiting. Yes, sir.
Similarly, if you have a very high small bowel obstruction, like a proximal jejunal stricture, or even gastric outlet obstruction is a type of intestinal obstruction, although we consider it separately. So in very high proximal small bowel obstruction, there may not be abdominal distension. So depending on the site of obstruction, these features may or may not be present. So in proximal small bowel obstruction, vomiting is a predominant feature, whereas in colonic or colorectal obstruction, vomiting is usually not there unless it is a very late stage, and abdominal distension is the prominent symptom. Okay?
Yes, sir.
Next.
Associated with weight loss of 3 kgs in the last 2 months. So,
Okay. Yes, carry on.
I could be suspecting it is not a significant weight loss because a significant weight loss is losing weight for 6 kgs in the last 6 months.
What is the definition of significant weight loss?
Losing of 10 kgs in the last 6 months, sir.
Is it 10 kg for everyone? For suppose you are 30 kg and somebody is 90 kg. So for both 10 kg is significant?
No, sir. It is involuntary weight loss, sir.
Yeah, but quantum. So it is not 10 kg, it is 10%. 10% of the normal when the patient was healthy. What was the weight? If the person or patient has lost more than 10% in last 6 months, or more than 5% in last 3 months, or some definitions say about 2 to 3 kg, irrespective of the duration. Because if there is a short history, like in this case, history is only 3 or 4 months, so you cannot wait for 6 months to say whether it is significant weight loss. Okay?
Yes, sir.
Yeah, so now what Dr. Ajay wants to know, that is the definition same for pediatric age group. Dr. Richa, what are there any norms for children to say that they have lost significant weight?
So, sir, when we say 10% weight loss, So, Dr. Kapoor has already answered that question. So, if the child weighs 30 kg and that child loses 3 kg weight in the last 6 months, then it becomes a significant weight loss. So you calculate by percentage.
10% stands even in children.
Whatever may be the pre-morbid weight of the child, if the child has lost 10% of that weight over a period of 6 months, then it becomes significant.
So, Mounica, what we are trying to tell you that whenever you talk of weight loss, you have to give the baseline weight. That so the patient has lost so many kg out of so many kg initial weight, if that is known. If that is not known, then you say subjective. So how do you subjectively say that the patient has lost weight?
If there is any loosening of the clothes he is wearing, and if there is...
Yeah, so if you know the exact amount of weight loss, you say. If you don't know, then you say that either the patient or the family members have noticed that he or she has lost significant amount of weight, but I cannot quantify because the patient has not recorded the weight. Current weight you can record, but you don't know the previous weight. But still you should try to ask the patient, maybe during a health checkup, maybe during admission to a college, or whatever reason. Some people on the, I don't know whether these days they are there, railway platform, there are weighing machines on the street side. Some people have weighing machines. So out of curiosity, people measure their weight, which they may not on their own tell you, but if you ask, they will remember. Okay. So the point we are trying to make is that it needs to be quantified. Yes, Ajay.
Adults will have a static weight. They put the weight loss in percentage, but children will have a gaining weight. So their static weight is also considered to be a negative factor. And weight loss will not be 10%, even less than that for a child who is growing. It depends on what age group he is and how much he is growing or that. If he becomes static, that is also negative for him.
Yeah, a child in growing age, if the child over a period of time doesn't gain the expected weight, that also is to be added to the weight loss. Okay.
Okay.
So I think this child's weight was 14 kg. So his current weight is 14 kg. So I presume that he will not be more than 20 kg. So how do we know that he has lost 3 kg? Because if he says that he has lost 3 kg, that means he knew his weight earlier and he knows his weight now. Isn't it?
Yes, sir.
So unless both the weights are known, you cannot quantify the exact weight loss. These are small points on which you should not get picked up by the examiner because they unnecessarily deviate you from the main case discussion. Okay? Yeah, carry on.
There is no history of obstipation, melina, and hematochezia. With no history of this.
No, first explain this. So obstipation history should have come as a part of the first sentence, because when we are talking of obstruction, as I said, these are 4 cardinal features. So no history of vomiting, no history of obstipation should have come along with the symptoms of obstruction. How you describe your negative points also tells the examiner that you know what all you are looking for.
Okay.
And what is obstipation?
Complete constipation, sir.
What is complete constipation? What do you mean by complete constipation? What is constipation?
Not able to pass stools for...
So it is, constipation is decreased frequency, amount, or change consistency of the stool. Even passage of hard stool is constipation. Passage of smaller amount of stool as compared to earlier is constipation. Less frequent passage of stool is constipation. So definition of constipation may vary from person to person or place to place. What is considered constipation in India may not be considered constipation in the West, because the food habits and stool habits are different. But what I am trying to tell you that there is a difference between constipation and obstipation. Do you know that difference?
As per definition, the constipation is not able to pass stool for 3 times in a week.
That is Western definition.
That is the standard definition. We don't have any Indian definition.
I think there is an Indian definition, because I remember Dr. Ghoshal, our colleague at SGPGI, he has done some guidelines. I don't know exactly, but definitions for Indians are definitely different.
So what we have importance is presently what we want to know is the inability to pass flatus and motion. That's what we want to know at this point.
So
for us, it is the practical importance, inability to pass flatus and motion.
Obstipation is when the patient is not able to pass even flatus. Okay. So patient who is constipated may be passing flatus, but if the patient is not able to pass stool and flatus, that is obstipation. So patient may be constipated but not having obstipation. But obviously, if the patient has obstipation, he is not passing stool and flatus both. Okay.
Yes, sir.
Next. So no history of melina.
It rules out the upper GI bleed, upper GI involvement, sir.
What is upper GI?
Because he was having bleeding per rectum also, so I have taken the history of melina and hematochezia. Above the if there is any bleed above the ligament of treats, it is an upper GI bleed, sir.
No. So from the point of view of GI bleed, how do we define upper GI bleed and lower GI bleed?
It is with respect to ligament of treats, sir. If it is above the ligament of treats, it is an upper GI bleed, sir.
And so, yeah. And if it is beyond the DJ flexure, then we call it lower
GI bleed, sir.
So what does melina indicate?
Melina indicates an upper GI bleed, sir.
So small bowel bleed will not cause melina?
Actually, if there is an increased intestinal transit and if there are any small right-sided colonic tumors, then also there can be a chance of melina, sir.
So melina is not synonymous with upper GI bleed. That is what I am trying to tell you. Yes. Upper GI bleed usually results in melina. So you have gastric ulcer, peptic ulcer. Yes, that will cause melina. And you are right that when there is a large amount of bleeding, there is rapid intestinal transit. So even a patient with gastric or especially duodenal ulcer bleed can pass even fresh blood per rectum because of rapid intestinal transit. But usually it manifests as melina. Lower GI bleed from small bowel or proximal colon, right colon, can also cause melina. What is melina? How does patient tell you that? Because patient doesn't tell you melina.
Offensive for black tarry stools.
Black tarry stool. So tar, which is used for surfacing the road, it is that color, that consistency. Okay. Yes. And what is hematochezia?
It is a bright fresh blood, sir.
Okay. So this is the point which Dr. Chaube was saying, that here you say there is no history of hematochezia, but next you will say that he had bleeding per rectum for last 3 days. So these are two contradictory statements.
Okay, sir.
Isn't it? So even if the history has been provided to you, you should have mentioned that I don't agree with this point.
Okay, sir.
Okay. Yes. Carry on.
And there is no history of painful defecation. This is for constipation. In constipation also, to rule out the constipation, sir.
So all patients who are constipated will have painful defecation?
Fissures.
Fissure in ano. The classical symptom of fissure in ano is severe excruciating pain when the patient passes or tries to pass a hard fecalith. He may not even be able to pass because of the pain, the sphincter goes in spasm. So he makes an attempt, but nothing comes out. And then it can precipitate pain. But more often it is the passage of a fecalith, because then the anal canal, mucosa or skin, whatever you want to call it, tears, and that is what causes pain. And there is bleeding, but that bleeding, what is the nature of that bleeding in fissure in ano?
In fissure, first the blood comes after the stools. First the blood comes, then the stools.
That is then what is hemorrhoidal bleeding?
What is hemorrhoidal bleeding? Classical?
Classical hemorrhoid. First the stool comes and then the bleed happens, sir.
Any of the residents? What is hemorrhoidal bleeding and what is bleeding on
fissure?
Hemorrhoidal bleeding will be in the pan before the patient will pass stools. Means it will be like a drop of gush of blood into the pan before the patient will pass stools. That will be hemorrhoidal bleeding. And bleeding from the anal fissure will usually be lining the stool itself and then followed by a few drops in the pan.
Let me tell you, there are 2-3 important things which you should know. One thing is patient is having pain on defecation with a streak of blood on the hard stool is usually suggestive of a sickness. Patient having bleeding, which is painless bleeding classically, separate from the stool, usually not mixed with the stools, can be before or after defecation, that is hemorrhoidal bleeding. Then what is mitochondria? She told us now that it is red colored blood, that is blood stain, fresh blood in the stool. It is blood mixed with fresh blood mixed in stool. Hemorrhoidal bleeding is also fresh blood, but it is separate from the stool. This is subtle ways how to understand.
Okay,
Yes, sir.
got it?
Yes,
What
sir.
Dr. Ajay said? Yes. Next.
There is mucus, no history of mucus discharge. It is asked to rule out inflammatory bowel disease, sir.
So inflammatory bowel disease, the classical presentation is mucus discharge perianal. What is the classical history of inflammatory bowel disease?
There will be diarrhea also, sir.
So frequent passage of loose stool with mucus, blood and pus is the classical picture. If you have only mucus discharge, what is more likely? It indicates a lesion in the rectum, like a polyp, like a polypoidal growth because of excessive mucus secretion. So mucus alone is not indicative of inflammatory bowel disease. Inflammatory bowel disease is diarrhea with mucus, pus and blood.
Yes, sir.
Okay. I think, Richa, am I correct in saying that children with polyp may have only mucus and then sometimes they may have blood?
Yeah, so you explained very nicely.
Okay.
Yes,
Next.
sir. Recently, patients started to complain of painless bleeding per rectum for the last 3 days, which is mixed with stools. This indicates carcinoma, sir.
Okay. Then
Not associated with tenesmus or splash of blood. As sir said, it is for to rule out hemorrhoidal bleed or hemorrhoidal bleed.
so what is tenesmus? Tenesmus is a feeling. The patient feels that he or she wants to pass stool. He goes to the toilet, he strains, but he passes either very small amount of stool or no stool at all. Okay.
Yes,
So
sir.
this indicates what? What is tenesmus? Tenesmus, the classical symptom of? It is a symptom of something in the rectum, something which is occupying the lumen of the rectum. So again, a polypoidal growth in the rectum, cauliflower growth in the rectum is likely to cause the sensation of tenesmus. A large polyp also can cause tenesmus if it is there in the rectum.
Okay.
Sir, can I interrupt?
Yeah. Yes, please.
Mounica, if I heard correctly, you said that a history of painless bleeding per rectum for last 3 days, which is mixed with stools, indicates a carcinoma. Did you say that, Mounica?
Yes, yes, ma'am.
No, beta. You cannot. That is not true, है ना? So I think you are biased because there's a positive family history of malignancy.
Okay.
But an 8-year-old child who has a history of chronic anemia and who has painless bleeding per rectum, your first diagnosis will again be a polyp.
Okay.
Say when you have a history of bleeding per rectum, you have to differentiate, all the discussion which we are having, differentiate between painless bleeding and bleeding which is associated with either abdominal pain or tenesmus. So you have to categorize. So painless bleeding in pediatric age group, your first differential diagnosis is polyps. That is by far in frequency the commonest.
Okay, ma'am.
Yeah, Richa, please go ahead.
So if I even looking at your entire history, I would say that maybe the patient has polyposis right now, and polyposis is a predisposing factor for malignancy. So maybe he's that would be your first diagnosis. Then, of course, there are much lesser common causes of painless bleeding in children, but please don't put carcinoma as the first diagnosis of painless bleeding in a child.
Okay, ma'am.
So, as Dr. Vikas said, the commonest cause of bleeding per rectum in a child is polyp. In fact, a pediatrician can make the diagnosis the moment the mother says this history that the child is passing blood in the stool and there is some mucus also.
Okay.
And even if you know the diagnosis in the exam, you should not make the diagnosis of malignancy based on the history alone, because all this can very well fit in with just polyp of the polyposis disease. Okay?
Okay, sir.
Yeah. Carry on. Next.
There is no history of perianal discharge or awareness of a lump. Perianal discharge is asked if there is any abscess near the anus area.
Abscess, the commonest symptom is discharge. What is the classical presentation of a perianal abscess?
Pain, sir.
Pain. So severe pain with fever. Discharge is when the abscess ruptures.
Yes,
So what
sir.
is which is the disease which has a classical history of perianal discharge? Just discharge, nothing else. It is fistula in ano. When you have fistula in ano, the patient complains that there is perianal discharge which is consistently soiling the undergarments. So that is the classical history of fistula in ano.
Okay, sir.
Okay?
Yes.
Yes.
There is no history of incontinence to gas or stools or of soiling of undergarments. It indicates, as sir said, to rule out fistula in ano, and
Yeah, soiling would be for fistula in ano. Incontinence also can cause, and incontinence we know that it is usually more kind of obvious at night. So a patient who is continent during the daytime may have incontinence during the night, resulting in soiling of the garments.
okay. And
Yes.
there are no history of urinary complaints. It is for hemolytic uremic syndrome if there are any involvement of urinary tract.
Yeah, so again, since this is a child, we are only considering polyp or polyposis. We are not seriously thinking of urinary complaints, but in an adult, when you have a malignancy or suspicion of malignancy in the rectum and the patient is a male patient, then obviously you have to ask for and look for urinary tract involvement. Okay?
Okay, sir.
Yes.
And there are no other constitutional symptoms like fever to rule out any Cox abdomen.
Yeah, carry on.
History of blood transfusion 1 month back with complaints of bleeding. Then, however, HP was low. It indicates.
So again, this is the
anemia.
point which Dr. Chaube was asking now,
Yes,
that
sir.
and now you are saying with complaints of bleeding. So we are not sure what you are trying to say, whether the child had bleeding per rectum 1 month ago or only 3 days ago.
Okay, sir.
So I know that this case capsule has been provided to you, so you are not at fault. But if a case capsule is provided to you and you find some mistakes, you
Yes.
should point that out. And the best way to do that when you are making an online presentation is mark your comments in red or in a different color. So we know what has been given to you and what is your observation.
Okay,
So
sir.
immediately you should have said that there is inconsistency in the capsule which has been provided to me, that whether the bleeding per rectum is 1 month ago or it is 3 days ago. It is possible that the transfusion was given because on routine test they found hemoglobin to be 6.5 and they thought that the child has been bleeding, but we need to know exactly.
Yes, sir.
Yes. So that is what the my team says, that it is basically the transfusion was given because of low hemoglobin. There was no history of rectal bleeding. They thought that the child is bleeding, but there was no history. So again, what we are trying to say that when you present a case, you must make sure that you don't make contradictory statements.
Okay, sir.
Okay? Because that unnecessarily causes interruption.
Yes, sir.
But this, what does this indicate? A hemoglobin of 6.5. What does this indicate?
It could indicate some impending anemia, sir.
Anemia is all right. In a setting of whatever history you have given, what was the possibility? Why anemia? Anemia is low hemoglobin by definition is anemia.
Yes, sir.
But why anemia occurred?
It could be
in this
nutritional.
particular time.
So you said it is nutritional. Why should there be nutritional? Although you did not mention specifically, but has the child developed anorexia? Is the child not been eating?
No, sir. Child is eating, sir. He
Okay.
doesn't have
What
any
else?
anorexia.
What else could be the possible cause of low hemoglobin? In a child who has bled per rectum 3 days ago. 3 days ago, definitely he has had bleeding per rectum.
Yes, sir.
So it is possible that the child was bleeding earlier and nobody noticed it, isn't it?
Yes, sir.
If it is a very small child, the mother would notice, but he is 8-year-old child. So possible that nobody ever noticed that the child is having bleeding per rectum.
Yes, sir.
What else could be the cause of anemia? Common cause of anemia in children?
Iron deficiency anemia, sir.
Because of? What is the socio-economic background?
Middle socioeconomic status, sir.
So what is the common cause of anemia in children in our country? Richa, am I correct in saying worm infestation?
Yes, sir.
So that's correct, sir. And in fact, Mounica, when you said nutritional, that was also okay. Like you could say that in the background of this history, as Dr. Kapoor said, maybe the child was bleeding earlier, but he did not notice. And bleeding was noticed only when it became significant. So that is the first possibility that you would entertain. Nutritional is another one, and third one is worm infestation.
Okay.
And then would come rarer causes like celiac disease, etc., etc. So those are much rarer.
Okay, ma'am.
Yeah, carry on.
There are no comorbidities or past surgical interventions. So I asked for comorbidities to check.
I don't know what comorbidities we expect in a 8-year-old child. Comorbidities in parents may be all right, which may be familial, but I don't know if do we specifically ask an 8-year-old child for any comorbidities? I am not sure. Richard, do we?
Maybe what Mounica is trying to say, no significant past history of any illness. But Mounica, in this context, Mounica, since you are considering polyposis syndromes as the first possibility, we are not talking of isolated polyps. We are talking of polyposis syndromes because there's a positive family history of malignancy. Then there are a lot of polyposis syndromes which have associated issues. See, juvenile polyposis coli is one, FAP is one, Pews-Jeghers is another one. Then there are other syndromes which have, osteomas, skin lesions, skeletal lesions. So maybe, that could be relevant in this child.
Purpura.
And also you mentioned no surgical intervention. Suppose we are thinking of polyp or polyposis. Is it only surgical intervention or any other intervention could be possible?
Endoscopic intervention.
Endoscopic. That is also very likely. So you should say no surgical or endoscopic. See, when you mention these things, it immediately tells the examiner what is going on in your mind. What is your thought process? Okay?
Okay, sir.
Yeah.
18-year-old child can have addiction to chocolates.
I don't know whether medically that is defined as addiction. Ajay is saying 80-year-old child can be addicted to chocolates. So, okay, let's move on. Yes.
So there are.
Yeah, fine. Go on to the next. Let's move on.
There are no history of any addictions, non-vegetarian and normal sleep, which diet has been asked to rule out. He doesn't have any megaloblastic anemia or vitamin B12 deficiency. And
how can you say that? You can't say that on history.
Okay.
No?
Yes, sir.
Okay.
And drug history, some drugs can cause bleeding tendencies. So it was asked like NSAIDs.
Okay. Next.
Family history, father has.
This is happening like one of my residents, he was taking a history And then we have put down all the points from KDAS, that book for surgical history now. So it was mentioned that there is no menstrual irregularity. A 37 years old male, no menstrual irregularity. So we don't need to point out everything which is mentioned in the book. It is in reference to this patient. That is important. So not everything has to be mentioned. It has to be relevant to this patient. You know? So there is no addictions. Normal sleep pattern doesn't make any significance in the child, maybe possibly. And comorbidities definitely will not have much influence on that. Definitely, if it was a 58 years old man, maybe I would have taken some things into consideration of some of these points. He was non-smoker, he is a chronic alcoholic. Does he have a history of chronic liver disease, suggestive of diseases? Does he have a pulmonary function which is altered? Does he have dyspnea on exertion? These all become important in a 58 years old man, but not in an 8 years old child. So we have to take it into consideration according to what we are seeing now, not all the points.
Okay, sir.
Yeah, next. So what we are trying to say, all the students, that do not make statements which almost sound kind of absurd. It should be important, relevant statement. Okay. Yes.
Family history. Father has a positive family history of adenocarcinoma T3N1. It indicates that he has a positive family history. Grandfather also has a carcinoma of urinary bladder. So it is in favor of.
So father having right hemicolectomy at the age of 30. Why
Yes.
did you specifically mention his age, father's age, when he had right hemicolectomy?
Because in the for HNPCC syndrome, for the diagnosis, they should have been diagnosed of adenocarcinoma before the age of 40, sir.
Yeah, good. So 40 or 50? I think it is 50. I also don't remember. So I have brought the notes from my book. It says HNPCC 1 CRC diagnosed before 50 years. So yes, very good that you mentioned the age, because if any member of the family or the index patient has developed colorectal cancer before the age, which according to me is 50, then you start thinking of HNPCC. Good, very good. Yes. Then.
And even his grandfather also has a carcinoma urinary bladder. It also indicates the positive family history, sir, for HNPCC.
Yeah, I tried to check, but I did not, in my list at least, I did not find urinary bladder. It's mainly colorectal, genital tract in the females, and pancreas. But maybe lower down in the list, urinary bladder also is there, but I don't remember exactly. Please, students, please check from standard textbooks that in HNPCC, in other cancers, other than colorectal, what all cancers are included. Okay?
Okay, sir.
Yeah. Next.
Abdominal distension. Complaints of abdominal distension relieved after passing stools with recent history of painless bleeding PR with a positive family history of large bowel cancer and bladder cancer, which my disease could be polyposis syndrome leading towards the malignancy, sir.
Yeah, so as Dr. Richa said, that you should not make a diagnosis of malignancy at this stage. What
Okay,
you should
sir.
say that I think the child has polyp, maybe polyposis. What is the difference between polyp and polyposis? Polyp means a polyp. Polyposis means multiple polyps. And when do we call it a polyposis syndrome? The classical FAP? When you have more than 100 polyps in the colon. We'll come to that when we come to endoscopy. So based on this history, yes, definitely the child has either a polyp or polyposis, but you cannot make a diagnosis of malignancy. You can't say that the child has malignancy. You should say that with a strong family history of cancer, and especially father developing cancer at a very young age, I would like to exclude, and because there is history of significant weight loss, I would like to keep in mind the possibility of malignancy and would like to look for it or exclude it. Okay?
Okay.
Richa, is that right?
Absolutely right, sir.
Ajay, you want to add anything? So you agree that at this stage, the student should not make a diagnosis of malignancy. Okay. So whenever you have a very young patient or a child, and even if the history is strongly suggestive of malignancy, you should be very careful before you make a diagnosis of malignancy. So my suggestion would be, by and large, you should say that this is the history. It is strongly or highly suggestive of malignancy, but the patient is very young. So I would like to rule out malignancy, or I would like to exclude malignancy. And other possibility, not in a child, but in adolescents, young adults, when there is a strong suggestion of malignancy based on clinical or imaging ground, you have to keep the possibility of lymphoma in mind.
Okay, sir.
Okay? Yes.
The only thing is, Monica,
Yes,
that if this child did not have a strong positive family history of malignancies,
Yes, ma'am.
then perhaps, a child who presents with a short history of painless bleeding per rectum, you could just do a PR in the OPT. If there is a polyp, remove the polyp and keep the child on follow-up. But this particular child, your threshold of suspicion or your index of suspicion for malignancy is high, and therefore the child should have a proper colonoscopic evaluation by a gastroenterologist.
Yes, ma'am.
So that I think would be a difference in the approach to investigating the child.
Okay, ma'am.
Mounica and other students, there's a dictum in exam, whenever you make a rare diagnosis, you are rarely correct. So don't just desist from making a rare diagnosis. That also gives an indication to the examiner that you know the diagnosis. In an 8-year-old child, even with a very strong family history of polyposis, 8 years is not the age for developing malignancy. Father had at 30 years. By definition, it is 50 years.
Okay.
So,
Yeah.
Diagnosis, rare diagnosis.
You should be very careful.
Yes, sir.
Don't easily disclose your card. Don't examiners get very bugged up. Ask opinion.
Yeah. Please carry on. Examination.
Examination. Patient is conscious, oriented, and comfortable. He is averagely built and nourished. Vitals, pulse rate is 108 beats per minute. Blood pressure is 90 by 60 mmHg. Respiratory rate is 21 per minute. Febrile. Saturation is being maintained on room air at 98%. ECOG score is 0. Weight is 15.4 kg. Height 108 centimeters. BMI is 13.2. There are no signs of pallor, icterus, pedal edema, generalized lymphadenopathy, and cyanosis.
What is ECOG?
Performance score, sir.
So what
It
does
is-
what does ECOG stand for? What is the full term? It is Eastern Cooperative Oncology Group. So this performance status score was devised mainly for patients with malignancy. But many groups, many centers have started using it for non-malignant conditions also, because it gives you a good overall overview of the performance status of the patient. Otherwise, for non-malignant diseases, there is another score which is used, which is called
Karnofsky, sir.
Karnofsky score, but that has scale from 1 to 10, so it is little more cumbersome to remember, and that is why most groups, even for non-malignant diseases, follow the ECOG. Okay. Yes. 0 to 100. Yes, Karnofsky is, sorry, 0 to 100. Dr. Anand corrects me. Not 1 to 10. It is 0 to 100. Yes. No. Okay. Carry on. Yeah.
On systemic examination of abdomen, on inspection, abdomen is flat. All quadrants are moving equally with respiration. Umbilicus is centrally placed and inverted. There are no visible sinuses, engorged veins, and pulsations. No visible lumps. Hernial orifices are normal, and flanks are empty. On palpation, inspector findings are corroborating. There is no local rise of temperature, soft and non-distended. Liver and spleen are not palpable. There are no other palpable masses. Hernial sites are normal. On percussion, liver span is 11 centimeters in mid-clavicular line. There is no shifting dullness. Auscultation, normal bowel sounds are heard. Per rectal examination, mobile polyp of less than 1 centimeter size palpated at 6 o'clock, just proximal to anal verge with normal fecal staining. No evidence of melina or hematochezia. Summary, 80-year male without any comorbidities presented with complaints of painless abdominal distension relieved with passage of stools with recent onset bleeding per rectum for 3 days. On examination, ECOG score is 0 and with unremarkable abdominal examination and on PR, a form mobile polyp noted at 6 o'clock position.
What is your diagnosis?
It could be a rectal polyp, sir.
Could be or it is. You have palpated a polyp. It is a rectal polyp.
Yes, sir.
What you have to say, it could be a polyposis syndrome because you have felt only one polyp. You don't know whether there are more polyps. If there are no other polyps, then it becomes a rectal polyp. If there are other polyps, then it becomes a polyposis. Isn't it?
Yes, sir.
Yes. And again, at this stage, you should say that because of a strong family history, 2 first-degree relatives, because father and grandfather both are first-degree relatives. 2 first-degree relatives having malignancy, 1 having colorectal malignancy, 1 developing colorectal malignancy at the age of 30. So these are strong points. 1 is history of malignancy, 2nd is which malignancy, and 3rd is age at which malignancy occurs and the degree of relationship. So these are all important points. You should say that I would like to rule out or look for a malignancy in the child also, although he is only 8 years old. Normally in polyposis, what age the patients develop malignancy? Normally?
At around 20 years, sir.
Yeah, after adolescence. That is why we wait for them to become complete their teenage, and that is the time when definitive surgery usually is offered. Okay, so 8 years is a very unusual age, but because of the strong family history, you should say that because if you say only polyposis, then I will question you that how is it that you are ignoring the family history? How is it that you are ignoring the weight loss? But you should not make a diagnosis of malignancy just on that. Okay?
Yes, sir.
So what will you do? This child is brought to you in the OPD by the parents. What would you do?
I would like to evaluate further by sending CBC and creatinine and a colonoscopy to look out the other polyps in the GI tract.
Why CBC?
Because he's having a bleed, I would like to know hemoglobin and counts, sir.
Why counts are important?
Because if in infectious colitis also there could be this kind of presentation, sir, bleeding per rectum.
Sorry, which colitis?
Infectious colitis, sir.
Do you think this is infectious colitis?
No, sir.
What is the classical presentation of any infectious colitis? It will be fever, diarrhea, and blood and pus, isn't it?
Yes,
short
sir.
duration. So where bleeding is the predominant symptom and there is no diarrhea, there is no fever, I don't think you would entertain a diagnosis of infectious colitis. So hemoglobin is important, agreed, because the child has been bleeding. At one point, hemoglobin was 6, only 1 unit of blood has been transfused. After that also patient has been bleeding, so agreed. And you said creatinine. Why creatinine?
It's for hemolytic uremic syndrome, sir. Because the patient is 80-year male, definitely it could be a polyposis. As in my DD, I have kept.
So, Richa, would we consider any differential diagnosis based on clinical picture?
Mounica, first of all, why are you repeating hemolytic syndrome as your DD? At least I'm not being able to understand.
I have read that even in the 80-year child with bleeding PR, it could be kept as one differential, ma'am.
See, Monica, you have to understand, when we read textbooks, for any symptom, there are causes mentioned. Those are the theoretical causes,
Okay,
which
sir.
are possible. But when you are doing a clinical case discussion, you have to discuss only the common causes, which are probable, which are likely. So something which is possible 1 in 100 times, you don't discuss when you discuss a case. When you are answering a theory question, yes, you mention all possible causes. So that is the difference between theory and clinical.
Monica,
Yes.
perhaps the way you are thinking is that in hemolytic uremic syndrome, the patient would have anemia, patient would have thrombocytopenia, and
Yes.
that thrombocytopenia will lead to bleeding PR. Is that your thought process?
Yes, ma'am.
Okay, but then there will be many more systemic features associated with that, no?
Yes, ma'am.
Yeah. So therefore, that should not come very high in your differential diagnosis. So your first differential diagnosis would be a polyp lesion. Now, whether it is an isolated polyp versus whether it is a polyposis syndrome, that definitely needs to be worked out because the approach to management of the two is very, very different. Then, of course, when you're doing the external examination of the perianal region and doing a rectal examination, look for hemorrhoids. That is another thing. Then solitary rectal ulcer syndrome is another thing which can present with bleeding per rectum, but the predisposing factor for solitary rectal ulcer syndrome is a history of prolapsed rectum, which is again common in children. Other thing is rectal varices. So they can also present. Then less common things are things like vascular malformations, which can present with painless bleeding in children. And then, of course, much less common are tumors. So the tumors that can occur in this age group are GIST, GI stromal tumors, and GI lymphomas. But they would not present with hematochezia. They would present more like, the kind of bleed which you have from tumors of the right colon or tumors of the proximal left colon. So actually, you're talking of lesions which are around the rectum. So polyps, hemorrhoids, solitary rectal ulcer syndrome, and vascular malformations. So that is the way we would look at it.
Okay, ma'am.
Okay, let's look at the colonoscopy report.
Yes, sir. So sigmoidoscopy was done. There were multiple small to large sessile polyps with a large polypoidal mass in the transverse colon causing luminal narrowing. Biopsy was taken and a strong possibility of HPS.
So, do you agree with this report? The sigmoidoscopy report. Read it again.
Yes, sir. Multiple small to large sessile polyps with a large polypoidal mass in the transverse colon
What
causing
investigation has been done?
sigmoidoscopy, sir.
And where are they describing the polypoidal mass?
They are describing it in the transverse colon, sir.
So does it fit? What is sigmoidoscopy?
Sigmoid colon.
Sigmoidoscopy is a short colonoscopy. Usually when we say sigmoidoscopy, it is a rigid sigmoidoscope which examines only the rectum and some part of the sigmoid, not even the entire sigmoid. If you do it with a flexible scope, you may examine the whole. So what I'm saying, again, there is a contradictory statement. If it is sigmoidoscopy, you cannot obviously examine the transverse colon. And if you have gone up to the transverse colon, then it cannot be sigmoidoscopy. So probably it was a colonoscopy.
Sir.
Yes. So is the report complete or you want to know something more?
Biopsy, sir.
No,
yes, sir.
just the colonoscopy. Just the colonoscopy report.
Yes, sir.
So as we discussed, the definition of FAP, familial adenomatous polyposis, is more than 100 polyps. So just saying multiple polyps is not good enough. Obviously, we don't want the colonoscopists to count and say that there are 230 polyps, but they have to say whether the picture is of FAP or there are less than 100 polyps, which is known as attenuated FAP.
Familial adenomatous.
Okay.
Yes,
So
sir.
just saying multiple is not good enough, because if they have seen multiple, they should have mentioned whether it is a classical picture of FAP.
Sir, can I add something?
Yes, please.
Sir, in this age group, when we are talking of polyposis syndromes, juvenile polyposis coli is much more common as compared to FAP. And juvenile polyposis coli is also a pre-malignant condition. And in juvenile polyposis coli, those numbers, that number criteria of 100 does not kind of, is not there as per definition.
So, Richa, is juvenile polyposis also pre-malignant? Because I thought that they are hypertrophic polyps. No.
They are hematomatous polyps, but they are pre-malignant. The only difference is that FAP, 100% malignancy, juvenile polyposis coli, the cumulative risk of malignancy by the age of 60 years is 60%. It is easy to remember this figure. Cumulative risk of malignancy in juvenile polyposis coli by the age of 60 is 60%. But when those hematomatous polyps undergo an adenomatous change, then they predispose to malignancy.
So I stand corrected. If you see multiple polyps, especially in a child, you have to consider the polyposis of the possibility of juvenile polyposis syndrome, where the polyps are hematomatous, whereas in FAP they are adenomatous. So in FAP there is a 100% chance of malignancy by the age the patient reaches 30 or 40 years. Whereas, as Dr. Richa pointed out, in juvenile polyposis, it is about 50% by 50 years of age, you said.
60% by 60 years of age.
60% by 50 years. And in attenuated FAP, where the number of polyps is less than 100, but when you do a polypectomy, it is an adenomatous polyp, then the risk is, I think, about 70%. So maximum risk in FAP, then attenuated FAP, then juvenile polyposis.
And Mounica, what will be your comment on CT abdomen suggestive of intersusception?
Yes, ma'am.
So do you really think that the child has intersusception, because that is a surgical emergency?
How does intersusception look on imaging? What actually do you see?
Telescopic appearance of there will be bowel and bowel appearance. There is telescoping of colon.
So a large polypoidal lesion can also give rise to a false impression of an intersusception. You think that there is something within the lumen which actually is the polyp. You are not seeing the base of the polyp. You are only seeing the tip of the polyp.
You know, this is very interesting what Dr. Kapoor said, and a lot of times a large polyp inside the lumen can be confused with intersusception. So how will you differentiate radiologically? An experienced radiologist can always differentiate. What can differentiate a true intersusception from a large intraluminal lesion giving a false appearance of an intersusception?
So this lead point, ma'am, transition.
So in a child, whenever there is an intersusception, you have to think of a lead point. So the polyp is acting as a lead point. But is there an intersusception or not? So the radiological feature which will help in differentiating whether this is polyp alone or whether there is an intersusception associated with it is the presence of mesenteric fat within the bowel lumen. Mounica, could you understand?
Yes, ma'am.
Yeah. So a good radiologist can differentiate that way.
Yes, ma'am.
I think we've already reached 10, so we will have to stop. But I think it was a good clinical discussion. I was thinking that we'll go into FAP and HNPCC, but time doesn't permit. Maybe we can have another session on that. But I think it was a good clinical discussion. So, Mounica, may I ask you which hospital, which institution you are?
I am from HN Hospital, sir, Mumbai.
And you are a student of which year?
Second year DNB resident, sir.
DNB in?
General surgery, sir.
You are a DNB second year general surgery student.
Yes, sir.
Good. I think for your level, it was a very good presentation.
And difficult case.
Yes.
So please tell us the diagnosis at the end of it.
Final diagnosis, yeah.
Yes, sir.
What were the operative findings? Yeah.
So he was operated for total colectomy and ileostomy with distal mucus fistula. Intraoperatively, there were multiple pedunculated polyps. And there is a large polypoidal growth causing luminal narrowing in the mid-transverse colon, sir.
Actually, Richa, we had a pre-operative diagnosis of malignancy. because
Okay.
the biopsy was positive.
Okay.
So Ajay has done a total colectomy because of the bowel edema. We could not restore, so he decided to do a stoma, and because we had gone with the idea that we will not create a stoma, we will do an ileorectal anastomosis and handle the rectum later because the malignancy is in the transverse colon. But bowel was very edematous and friable, and Ajay was not very comfortable doing the primary anastomosis.
Nice.
Okay, good, Mounica. Thank you very much. Thank you for volunteering to present.
Yes, sir.
Compliment for you. I think this is the best presentation by a general surgeon I've seen in last 10 years.
Yes.
You should get a credit for it. And
Very
even
good.
to be a MCH surgeon student,
Yeah.
and for a general surgeon, I think it's really commendable.
And second
Very,
year,
very good.
she's only second year.
Very good.
Good, very good. And I really admire you volunteering to present, because even MCH students are not coming forward. Good. And if you want to present more cases, please let Dr. Anand know.
Okay, sir.
Good. Thank you, Richa. Thank you very much.
Thank you, sir. Thank you,
for joining.
everybody. Thank you.
Yes.